Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown discussing hot topics in sports medicine and society.
All right, welcome everyone to our UCSF Sports Medicine Podcast, 6 to 8 weeks with myself, Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown. Today we'll be talking about myths in sports medicine. One of the things that we see as people are becoming more active or watching their favorite sports team is understanding what some of the things that we do to get athletes back on the field or our patients back into their activities may not necessarily be true. So one of the first things we hear a lot about, and I'll direct this question over to Brian, is that running is bad for your knees. What do you think about that, Brian, when patients come into your clinic and tell you, you know what, I don't want to run because it's going to give me arthritis?
Yeah, I think it's a really common misconception or consumption, and certainly some people do develop arthritis in the setting of running. The question is whether or not the running caused that, the running makes that symptomatic, or were you predisposed to getting that arthritis? So this has actually been pretty well studied, and there are some studies that show a lot of running. So let's say you run a marathon and you get an MRI before and after. It shows that your cartilage in that period of time after the marathon is a little bit less healthy. However, that hasn't been shown to correlate with your knees really breaking down over time. So there was a really nice study done partially at UCSF, partially at other places, where called the Osteoarthritis Initiative. And what they did a variety of different things. They've studied over 400 patients over an extended period of time, published a lot of papers. But the one regarding running shows that when they follow people that ran a lot versus people that ran a little bit and people that didn't run at all, the rate of cartilage degeneration, or the rate that people are developing arthritis, didn't really change. So this pretty conclusively shows that running isn't really bad for your knees per se, especially when you consider the added health benefits of running. It's going to decrease your weight. It's going to probably cause you to eat a little bit more healthy. If you're running consistently, you're probably eating a little bit better. It's making you happier, assuming you like to run. So I think overall, we can't really say running is bad for your knees. In fact, when people say, why do I've got to stop running on my knees, I usually just say, yeah, you probably can run on your feet instead. It's going to be a lot more comfortable. And it's really not that bad for you, especially when you consider the health benefits. So Drew, what do you think causes arthritis? Why do you think, if it's not running and if it's not overactivity, what are some factors that we should be thinking about?
Yeah, I think the development of arthritis is definitely multifactorial. So a lot of things go into it. And it may be that activity plays some component, but a lot of other things so your weight, so the more weight that you carry, the more stress that the knees are seeing. So that's one that people can actually modify and, look to decrease to take some of that pressure off the knee. And then prior injuries play a big part. So if you have an ACL tear in the past, or you have a fracture around the knee, things like that will predispose you to a higher risk of arthritis. And then I think some people are just more genetically inclined to develop those degenerative changes. So, we get a lot of people who, their dad had his knee was replaced, and, down the family line, everybody's struggled with arthritis. But so there's definitely some predisposition, just probably that cartilage isn't as durable as somebody else's knees. But I think, when we think about it, probably weight is the biggest modifiable factor. And then, keeping up good strength, good mechanics, all of that can likely help as well.
So do you think it's beneficial? Let's say you have a runner that's having some knee pain with running, maybe it's patellofemoral pain. Do you think it's beneficial to send them to PT? And if so, what do you think it does? And maybe Nirav, since you are a runner, sort of a runner, you answer too.
I think it definitely is. And so much of that pain comes from changes in the biomechanics of the lower extremity. So how the knee interacts with the hip and kind of the balance and the strength between it. And I think sometimes it's really hard to see what that's like in your knee. Even if you're a trained professional, understanding how your knee is when you're running, and just having that second set of eyes of somebody looking at it and saying, your form is good, your strength is good in this, or, hey, this is something that we can address and, get your mechanics better, get that strength better. And I think a lot of people can get by without physical therapy, but I think the quickest, most predictable way is usually to work with a formal, physical therapy program. What do you think, Nirav?
I agree. I think even 1 or 2 sessions is really good. I think where a lot of people get into trouble is when they get back to running after a long period of time, and they'll be like, look, I want to run this half marathon, it's marathon, and suddenly they go out and run 30, 40 miles a week. So not only are they overusing it, but their mechanics might be the great, or they're trying new types of shoes. They'll try like a shoe like a Hoka suddenly after wearing, a shoe that has less cushion in it. So I think a lot of it is a physical therapist not only can work on mechanics, but they can also work on things like how you should be training, or what shoe wears the best for you. So I think they can give you a lot of different guidance. And I think people do feel that just because their knees hurt when they're running, it's causing arthritis, when in fact, a lot of that pain is coming from the fact that they have bad mechanics. It's patellofemoral pain. And sometimes it's an excuse like, well, I don't want to run because it's going to give me arthritis. Because, for a lot of people, I think running, especially if you get back to it after a long period of time, isn't necessarily fun initially, and it can take 2 to 3 months to kind of get back and not have that pain come. But I think when people stick it out, they feel better. So absolutely, I think getting anyone to help you along, even if it is a running coach in your neighborhood or someone who's been running for a while, can definitely help in that process. Maybe Brian, when people come to you, particularly older patients, because you see an older population than me, what do you tell them when they say I want to start running? Like, what's your general guideline for like how much to be running, or what you should be doing when they want to start up?
Sure. So I think right now it's a great time to be a runner. I think what running is one of those things that you can get essentially outstanding coaching just from getting a simple app on your phone. So whether it's the Peloton app, not to, I think everybody in San Francisco now owns one, but sorry, Drew. But they have decent training programs for that. They have like Couch to 5K, Couch to 10K that really start small. And I think that's the general guideline is you don't want to start off, if you want to run a half marathon, the first step is run a quarter mile, come home, stretch, and do some cross training. And I try to encourage people to gradually increase their activity over the course of 2 months to 3 months, especially when they're returning from an injury like an ACL, and to take breaks and do some cross training, do some rest days, because strengthening different muscles around the legs will really help you, especially if you're building towards an endurance event.
Great. I think we'll transition to our second myth. And that's about slap tears and rotator cuff tears. And now obviously a lot of people will come in with shoulder pain, not me because of my bulk. That doesn't happen at all because I've got, great muscle tone. But for people with a little more atrophy like Drew and Brian, when you get an MRI, it'll show a rotator cuff tear or a slap tear. And people come in and say, this has to get fixed. I have something torn in my shoulder. Is that a myth or reality, Brian?
Yeah, I think overall that's a myth. So slap tears and partial thickness rotator cuff tears often don't need to be fixed. One of the hard parts about MRI is MRI has gotten better and better in showing us a really nice quality image of our bodies, is it shows us what normal looks like when we age. And certainly with the ability to see subtle things in the order of 1 to 2 millimeters, we're going to see things that we may not expect. So for an MRI, so let's say I come in with a left shoulder discomfort and it's pretty non-specific at age 40 something, there is over a 60 to 70% chance I'm going to have a degenerative superior labral tear or a slap tear. And it sounds horrible when you get that MRI. You look at it and it says type 2 superior labral tear, comma, associated with slap tear, or it shows undersurface degeneration of the supraspinatus in the crescent zone, high-grade partial thickness rotator cuff tear. And I think the hard part is one, we probably compensated for those for an extended period of time. 2, they may be normal age-related findings. It would be what I often tell my patients is, it's very similar to if I went to a hair specialist and said there was some anterior thinning of the amount of hair in the front of my head and there is some loss of pigmentation bilaterally on both sides. Nirav can sympathize. I don't know what kind of wig Drew wears, but sometimes that's just normal for age and it's not necessarily a big deal. Drew, I know you did a study about this looking at MRIs. What did you find?
Yeah, so we looked at.
I know, but I like to cite myself.
Yeah, but you're just looking at. I think it was like 500. It was several hundred MRI scans over a 6-month period here, and the goal was, because we had talked about this before, you and I, Brian, that So many patients come in and they come to us with that radiology report saying, I have a labral tear. And I think it's very natural. Like, my shoulder hurts. I got an MRI. It's torn. That should be fixed. Like, it's very logical. But a lot of times that doesn't really line up with the pain that they're having. It's just more of an incidental finding. So we just looked at all these scans to see how common it was to have that on an MRI. And like you said, once you're over the age of 40, 50, the majority of people do have that finding on the MRI. So that may be there. You could even scan, somebody before they develop pain, and they may have those changes, and it may not, be the thing that's causing the problem. And so, trying to figure out, is that what's driving symptoms is really the big question.
So along those lines, when does someone need surgery? I don't see this in my population, but when do you say, you know what, that cuff, that slap tear needs to get fixed?
Yeah, I think so. First of all, the indications for us to get an MRI are often different than the indications for a primary care practitioner to get an MRI. If I'm getting an MRI, it's usually because they've had an acute injury and I'm concerned about something that needs to be fixed surgically. So my indications for a rotator cuff repair are a full thickness tear that's symptomatic. And by full thickness, that means there's a hole in some part of the rotator cuff where essentially from the shoulder, you can see above and through the tear in the rotator cuff. And they have to have symptoms. Like, if you have zero symptoms, I can't make you better. And you probably shouldn't have gotten that MRI in the first place. Most of the data suggests that for a full thickness tear that's symptomatic, it is better if we fix that sooner, meaning in the next 6 months to a year, rather than later, meaning waiting the next 4 to 6 years. What about for slap tears, Drew?
I think a lot of people, we can get them better with like an exercise program, physical therapy, maybe an injection, but non-surgical treatment. And even a lot of throwers. So like high level pitchers, we can get them back to throwing where they have this finding on their imaging, but don't necessarily have a repair. And it's something that, I think we don't always understand which ones are going to cause persistent symptoms, but I would say the vast majority in my practice, I'll treat people without surgery. And then if somebody's going through physical therapy, they're trying everything else and the shoulder's not getting better, then I think that's when we'll, look towards surgery. But would say it's a minority for sure.
Yeah, I think my indications for slap repairs, especially for throwers, I think it's tough because as soon as we operate on throwers, the risk is they may not be a thrower anymore. But I will include people like rock climbers and some of the surfers that I see in clinic, just because it's a high demand, high risk sport. If you feel like you can't do your sport safely and you failed non-operative management, I will be a little bit quicker to fix a superior labral tear if it happened from an injury, not with degeneration.
Yeah.
Nirav, I'm going to throw in a bonus surgically related myth. Is it myth or reality that once you have surgery for a throwing athlete, you're going to come back better and stronger because you've had that problem fixed?
Well, with my patients, they always do, but for it's very surgeon specific. No, but in all honesty, I think a lot of people, particularly with Tommy John or shoulder surgery, they say, "Oh, I got better." The surgeon tightened up my muscles or made them stronger. And I think, for a lot of people, what that is not necessarily the surgery process itself; it's the physical therapy they do afterwards. So a lot of time, this injury is the first time they've actually worked with a therapist to work on their mechanics. So they come in for a Tommy John surgery, they come in for a rotator cuff surgery, and someone says, "Look, your core is really weak, or your lower extremity biomechanics are very poor," and they work on it. And it's not because they're, we've made anything better in terms, besides fixing their actual pathology, they're actually stronger and come back. So I think a lot of that, even though as surgeons, we like to take credit for people getting better, it's really the physical therapy and the mechanics and taking the time to understand your body for the first time that a lot of these athletes get better. So absolutely, I agree, it's a myth.
Yeah, I think Drew and I did a study about this a while ago, and it turns out even in the major leagues, you come back. So the rate of return is great, which is, I think, a testament to how well that surgery works. But what doesn't happen is you don't come back faster. You come back a little bit slower, and you change the amount of off-speed pitches. You increase your off-speed, decrease your curves and sliders, probably because you're a little bit nervous still. So it's football season, which means that most of us are covering football. And even if your team is 4-6, it somehow still made CCS. But one of the questions that comes up is, okay, I've had my ACL reconstructed. Therefore, I should be wearing a brace when I go back to playing sports, whether it's football or basketball or volleyball. But what about, should we be prophylactically bracing people to prevent injuries? And do braces decrease the rate of re-injury after an ACL tear? And Nirav, I think since you see the most high school athletes, we'll start with you.
Yeah, I think that's a question a lot of people have. And I think the data shows that it definitely doesn't decrease the risk in most athletes. There's some select sports where you may see it, whether it be downhill skiing or maybe football linemen. But I think in general, braces won't prevent the injury. And I think for a lot of people, what ends up happening is they depend on the brace, for that stability. So they may not necessarily do all their rehab. They don't develop that proprioception back, which is basically understanding where your knee is in space. And I think for a lot of high school sports, I know, Brian, you have daughters who play high school sports, that sometimes a brace becomes a target. People will go after you as well too, because you have that brace, particularly in sports like soccer or football. So I think in general, if you're using a brace because you feel like you're weak or there's still some degree of laxity, that means you have to rehab more, or you really have to think about, what sport you can be participating in. So I think in my eyes, the only group that I really will use braces in perhaps is in the very, very young patient, the 9, 10, 11, 12, or 13-year-olds who are still developing their muscle strength. They're still developing their neuromuscular control. They may need that brace because their body is undergoing changes that we can't account for or treat in physical therapy. But I'd be interested to hear what you and Brian do. I mean, Drew, you and Brian do in terms of bracing adult patients.
I'll usually recommend it, especially for skiers. And there's some evidence to say that that'll decrease re-injury risk. And so especially the first year after the reconstruction, where there's still, maybe a little bit tentative and, the confidence isn't there, like have the brace on while skiing. And most others though, won't use a brace. And what about you, Brian?
Yeah, I think the evidence supports that its use in skiers for returning to sport is pretty good. So I will use it in skiers. I will use it for year 1 to year 2, and for 2 reasons. First, like I said, the evidence is that it decreases re-injury risk in that first year. And second is, realistically, it takes 2 years to get better from your ACL reconstruction. So at 9 months, 8 to 9 months, we usually let people get back. But the reality is that if we look at neuromuscular coordination, which is what's going to control an injury, especially in fatigue, that takes 2 years to get better. And I think famously in the Bay Area, people are saying, well, if Klay Thompson really wants to protect himself, 2 years before he gets better. The reality is now that he's had 2 years, we will probably see a more refined, almost Larry Bird-like Klay Thompson with more lateral movement when he comes back. But part of that is going to be that his knee is fully recovered. For other sports, I leave it up to the patient. I will tell them, I think it might not be a bad idea. It does remind them, hey, you are recovering, but I don't make it an absolute. What about for football linemen? I think that's where we see almost a majority of the people that I cover when they're playing offensive and defensive line, they tend to wear a brace. What is that for?
So usually it's for their MCL, so the ligament on the inside of the knee. And there's definitely good evidence to say that bracing helps, and it just gives some extra side-to-side support. So if that knee is, bent that way, the MCL isn't sprained as easily. And then for somebody like a football lineman, they're usually able to still play, do everything, and not really be, interfered with by the brace. And so, you'll see it in them, not so much like receivers, cornerbacks, where they have to, be a little more dynamic in their side-to-side movements. And then a lot of other sports aren't really amenable to it. But, I think it's great, especially for like, if you're really big, like the, elite level, professional level linemen, there can be so much force through that MCL that brace can definitely help.
Yeah, and I think the evidence supports that as well, that it is going to decrease your injury risk. And for an MCL sprain, that's going to keep you out for 4 to 6 weeks. That's going to be half your football season potentially. So that is something that I usually encourage people who are, for lack of a better term, slower moving along the field and often can't get their foot out of the way when somebody's going to land on them. I think it's beneficial then. All right, so the last thing, and I should bring up that we chose these out of a potpourri of Twitter responses. The last myth that came up was whether or not people can have a high pain tolerance. So this comes up oftentimes. Patients will come in and say, well, I'm okay undergoing surgery because I've got a high pain tolerance, or I didn't come in earlier because I've got a high pain tolerance. So what do you all think? Is that true? Do people have different pain tolerances, and does it matter?
Yeah, I think in my eyes, I think people have different coping mechanisms for dealing with pain. So I think if you take two people, they don't, there might be some evidence that they have physiologically different, ability how their receptors, will respond to certain stimuli. But I think in general, we see the variations is how they emotionally cope with different stressors. So I agree. I don't think there's an inherent difference in their pain tolerance. It's just their ability to cope with whatever their body's going through. But I think for me, it doesn't necessarily change my surgical approach, in terms of whether we offer them surgery or not. I think it just changes how we're going to support them after surgery in terms of pain expectations, and particularly in the rehab process about how they're going to have to meet certain, steps or milestones along the way.
So Drew, let's say somebody comes in, let's say I come in and I say, I'm ready for my next knee surgery. I've got a really high pain tolerance. Does that change how you manage me? I mean, I came in late because I just blew right through it. It didn't really hurt me at all.
Yeah, I wouldn't believe you, for instance, but for others, if you said your next knee surgery, so if you've had prior surgery, I think that can be a good reflection of how you'll manage the pain. And I think that can probably be
well.
Yeah. But that's usually the best measure. And so, if you had a great experience figuring out, what was the anesthesia, what medications did you have afterwards, what exactly did you do? Because like trying to aim for that again. And then if you said, I usually have a high pain tolerance, but this was miserable, then trying to figure out, what was done and what we can do differently. Because it's, whatever that prior plan was, wasn't optimal for getting you through it. And I think, the pain and the whole experience, it's so subjective. And it's definitely hard to predict person to person, like, what it is that's going to, cause people to be in a lot of pain, and other people can seem like a huge surgery and, they kind of fly through it without any kind of issue. And, I think there's something there that, people certainly respond differently, but sometimes hard to pin it down ahead of time.
Yeah, so not surprisingly, the information out there on pain is really both complicated and there's a lot of it. One of the interesting things I found when I was looking this up was that pain tolerance does vary person to person, which is not surprising. We all have different abilities, but what modulates that is our coping mechanisms and our emotional state in the setting of pain. And that kind of makes sense. If you're, for lack of a better term, if you're in a bad place, you're anxious, you're really nervous about upcoming pain as well, your ability to tolerate that pain is going to be much lower than if it's something that you're kind of accustomed to. And I think we see that a lot in people with arthritis. They come in, they have what looks like really clinically significant arthritis. They're limping. They have bone on bone changes on their x-rays. And they say their pain's a 2 out of 10 and they're used to it. They cope with it well. And it's not pain that's really driving them. It's their lack of ability to function that's driving them to come in and see us. So I think, I agree with what both of you said. We shouldn't modulate how we treat patients, because having a higher low pain tolerance is going to be more based on emotional state, not who that patient is. And the people with very high pain tolerance probably are just more habituated, and we should turn back towards kind of what's more important for us, which is managing function. So even though pain's really important, better outcomes and better patient happiness after surgery comes more from treating function rather than treating pain for probably most of the musculoskeletal injuries that we see.
Great. Well, we covered just kind of 4 major myths today in sports medicine. So once again, thanks everyone for listening to our UCSF Sports Medicine podcast. And we look forward to getting more people's questions answered as we move on with our series. Thank you.